Dr. Moore, I'd like to start with you. And you're pioneering this concept of a hospital without patients. So tell us what that means.
Thanks. Mercy is a large health system. We're a little over $5 billion, 45 hospitals, a couple thousand integrated physicians, and another 1,000 mid-levels. So we're fortunate to have a long history, and we've been on about a 10-year journey that's focused on how can we reinvent the model of healthcare. How can we take what we do in the hospital and both augment it, but why is the hospital the epicenter of the health system many times when that's not where most of us look forward to landing? So let me explain what we're doing in terms of a patient. Naomi was one of now 300 plus patients in a new program we started in the last year. But prior to entering the program, Naomi was hospitalized 13 times in our system, like a lot of the other folks, over a 2-year period. She's 87 years old, had 30 different conditions, multiple medications, seeing lots of docs, everything we could throw at her. She kept coming back in our hospital, but it spoke to what we could do. So for 13 times with 2 primary cancers, a lot of illness going on, we were able to take Naomi, augment our continuum with what we do virtually in the hospital. ICU teams, hospitalist teams, other sepsis teams, things that are all done virtually outside, augmenting what we do inside. And we got Naomi home over and over again. But we said, what happens? What if we really rethought it? What were we doing? Most of the time we weren't doing an operation invading her body. We were taking a person who was very sick, who needed a continuum of care. And inside the hospital was the one place you can really get a continuum of care. Physician-led, interdisciplinary, intensive care plan with people responding within minutes when something went wrong. That's why Naomi got to go home over and over again. So what if we took that and said, what if we could do that with technology in the home? So we did build that, a dedicated team that was not a separate team. They were working with the entire healthcare system, everything Naomi already had. Fast forward, 9 months, instead of 13 hospitalizations and $487,000 in cost, Naomi got her 3 wishes. She wanted to play bingo on Tuesday nights. She wanted to be independent in her home, and she wanted to spend more time with her kids. And she did all 3 of those. And about 9.5 months later, she died peacefully in her home, or in her daughter's home for the last 2 weeks, at a dramatic reduction in cost. Also a dramatic reduction in reimbursement, a separate issue we could talk about later. But which system do you want? It's the same system. On the one system, paid almost $500,000 for dramatic rescues. In the new system, intervening on Wednesday instead of Friday, we could tweak your care with a 5-minute response time, 24 hours a day, and she doesn't go to the hospital. She had a total of 2 days of hospitalization in the last 9.5 months of life when it should have been escalating. That's rethinking what's possible.
And that's possible because your model is to basically have a call center is probably not the exact analogy, but something like that, where you've got on-call physicians, nurses, medical personnel, basically providing that same care she would have gotten in the hospital.
Correct. We have a 125,000 square foot facility, state-of-the-art, with 500 plus dedicated FTEs. They're doing virtual care 24/7, 365.
To patients who are not in the building.
To both. We are both taking care of about 1/3 of our patients at any given time are inpatients, and about 2/3 are outpatients. So the key is not virtual care telemedicine separately. It's how to use the technology to take care teams and make it fully person-centric, consumer-centric, 24/7, 365. Because we are patient-centric in our clinics, when you're in our hospital, if we're in your home, but 98% of the time, that's not where people are.
We'll come back to that. Dr. Schoenberg, I want to talk to you about your company, American Well, where you're also based on this concept of saying the care should be really where it's needed the most. Tell us a little bit about your idea and how, let's just address it from the point of view of how much of the medical care that we provide doesn't need to be in the hospital. You know, how much of it is this continuum of care where we can be smarter about how we provide it and more efficient?
Yeah, so Alice, we are in violent agreement, by the way. And we couldn't be more excited about the future. We think that the headline is not the hospital going down, but rather care is moving home. And all of us are going to age gracefully in our home, and if we have a serious illness, we can spend more time with family and friends and get a very high quality, accessible, affordable care at home. This is not a one company effort, to be clear. This is a very big village that is contributing different elements of this solution. So the chronically ill patient is going to be in our home, connected to wearable and non-wearable devices. Instead of having a lab results every 6 months, our bodies are going to emit continuously millions of signals that are going to go into the cloud. And companies like Apple and Samsung and Philips and many others are very focused in enabling these solutions. And then in the cloud, you have millions of data points. So you need very different systems to analyze it, to create precision medications, to create evidence-based guidelines. And companies like IBM Watson that are here today, Advisory Board Company, Optum, and others are really creating fantastic solutions that are able to create these personalized care plans. And then risk-bearing providers and payers are going to be financially motivated in order to close back the loop with the patient and have the doctor reach out to the grandmother and say, hey, you gained a pound a day in the last week, before you may not even noticed it. It's not your diet, it's your heart. And someone will knock on her door with a bag and a medication that is very affordable that comes with support to change her therapy. Again, companies like Teva and Pfizer and others understand that their new role is not only to create molecules, but rather to improve outcomes. Essentially, unlike others, we don't really believe that the roles of the players are going to go away. Our doctors was here 1,000 years ago in the cave, and we trusted our doctor. And we have cancer, we still need to see a doctor. The communication modality is going to change. So people that understand risk like payers are going to survive. Employers may or may not be part of this story, but certainly consumers, informed consumers are going to be there, and of course different types of providers that are going to enable highly automated systems. So as I said, we can't be more excited about it. We think that you're going to see this change much sooner than people realize. Currently, about 2% of care is provided online in America. We think that within 3 years, you're going to see 20 to 30% of care provided. But unlike most telehealth companies, we don't think that people will talk to the doctor in the box in the cloud, but rather doctors are going to have electronic communication means to communicate effectively with a patient who is not in the room. And there is a very big difference between those two viewpoints.
And Dr. Topol, I want you to pick up on that because you're focused for many years now on patient empowerment and really changing the model to say in that doctor-patient interaction, does the doctor have to be the authority figure? And tell us a little bit about the sort of patient MD concept that's emerging now.
Sure, Alice. Well, I think these points have been excellent. We have a very paternalistic medical community, and we have a design of a hospital, a place where you can't, in regular hospital rooms I'm talking about, a place you can't sleep. You have a 1 in 4 chance in America of being harmed, and it costs an average of $4,600. That isn't a very good design. So the question, of course, is it's not going to be the hospitals that change the system, because they have obviously that's the model. But there is a much better way going forward, not so much for intensive care units or operating rooms, but the main effect is the regular hospital room. It will be in the patient's home. And because of the availability of sensors and telemedicine, patients are going to have an outcry to use this rather than to be hospitalized. We've already been seeing this in emergency room visits because people can now, for example, heart rhythm, transmit that. They get an algorithm to interpret it. They can transmit it to their doctor, and that can preempt having to go to an emergency room. So the more people experience this empowerment with not just being able to generate their own data, but have algorithms to interpret that data accurately, the less need there is on the traditional model. So I think hospitals as they exist today, which George Orwell characterized long ago as the antechamber to the tomb, it's still today, unfortunately, there's a lot of problems. We have a much better model incorporating this new technology. In fact, what's happening in St. Louis with a virtual surveillance center can be scaled. Really, the question that comes before us is this going to be a local community story like at Mercy, or is this going to be remote and outsourced to other countries for surveillance? And hopefully it's not going to be outsourced. This is really something, ideally, there would be continuity. No one's undermining the importance of physicians and that relationship, but there are better ways to give routine care for non-acute intensive care type problems.
We're going to open up to questions in a few minutes, so start thinking about this, and I'm sure we're going to have a lot of really pointed questions about what this huge paradigm shift is going to mean for people, for the medical profession. But Dr. Moore, I'd like to ask you, what kind of feedback have you gotten from this type of surveillance? I think initially, for most people, telemedicine means remote access, places without the medical care that doesn't have the expertise. How do you sort of overcome that hurdle and, make people think about this as the medical care of the future, that yes, this is sort of the way to go?
Well, again, if you come back to the one place that we keep patient centricity is in the hospital, you can live a block away from the hospital and have poor access to care and untimely access to care. So first, from feedback we get from patients, in general, when you really connect and you integrate into the system, you don't disintermediate. People who have never touched technology, which a lot of our patients haven't, and now are working on an iPad or something else from their home, say, wow, I'll never go back. In fact, another story, a guy who was a Vietnam vet, who we air vac 3 times from the middle of the Mark Twain forest, 100 miles away from anything, for his heart failure. We put him on the program, and he's now a year without going back in the hospital. He's using technology remotely. And his experience right now is saying, I was in Vietnam for 18 months, never saw the inside of a helicopter. Now I saw it 3 times in 3 months, but this new program where you're actually coming to me, he asked us a question. He said, what took you so long? All right. And really, it's we haven't rethought healthcare and what's possible. We've used the hospital infrastructure because we built it. And because that's where our doctors and our teams are. But we progressively used it for chronic disease, which slowly deteriorates out in the community. How do we keep Mike home and not in a helicopter? We focused on him in a proactive way, just like in the hospital. And on Wednesday, we tweaked his care with a team who could respond on a real-time basis. And on Friday, he didn't see the helicopter in the hospital.
How much of that care, we often hear from doctors, when patients do get admitted, we'd like to keep you overnight to watch things for observation. How much of the care that we provide now is that almost default, protective measure?
It's actually terrible because you could actually do continuous vital sign monitoring, much more exquisite than you would get in the overnight stay for observation at home, for a tiny fraction of the cost. We have the technology today to do this, but we're not using it. So yes, that kind of whole model of observation or putting people in regular hospital rooms where they get once a shift, maybe vital sign monitoring, and things can happen, of course, in between, that doesn't really work very well. And we can do so much better than that.
We're going to hear after this, I think, from a company, we're doing some work with Vital Connect that has a patch. That's doing the same thing. Slap a patch on, continuous monitoring, no personnel. But a key is we have to have teams that can respond to actionable information brought up earlier. And there's another big piece here. When Mike came inside of our hospital and was air vac'd, we were paid. For what we're doing right now, we're not paid. And we have to realign the system. It's not paid versus not paid. It's what are we paying for? Healthcare for a long time has been paying for reactive sickness care. I don't know about you guys, but I'm not looking forward to the excellent bypass surgery someday. I'd rather never need it. And that's what I'd like my health system to be paid for. So it's paying for outcomes and health status as opposed to late reactive sickness care. And if we don't tackle that issue, it's not going away. Fortunately, we're a faith-based system, and the Sisters of Mercy, we're all about going to care proactively, but we took a leap of faith. 10 years ago. We started building this model. But we've spent hundreds of millions of dollars for something that's not compensated. Now, we've done it because we believe the system is going to value, it's going to outcomes, and it was the right thing to do. But that's a major issue. Final point I want to make is, as been brought up earlier in the conference, we can't do this by ourselves. We have a $3.1 trillion system that has 1,000 different answers to present on how it should be done, confuses the heck out of people. When you get sick and try to migrate the system, it's near impossible. We've got to come together. Technology, common platforms, but much more important, common experiences.
I'd like to add maybe one more point. There is science and there is psychology. And in healthcare, the most important word is trust. When I have a serious heart condition or cancer, I'm very, very anxious. So while we can do, I believe, most of care automatically at home with remote care today, including ICU, we still need to get over the hump of getting people comfortable of getting this care. In the same way that automated pilots can pilot our aircrafts, but we still like to hear the captain when there is turbulence. So we still believe that the biggest effort is for everybody to stand behind those solutions and take the patient's hand and reassure them that this is actually going to work.
Mm-hmm. And that builds integration too. With a system in general, and our approach is not to have Mercy Virtual View as a standalone silo, but as an augmentation of what the patient can experience on top of today. So we don't take a Naomi and pull her out of her primary care practice and everything else.
Right. It's working with it.
It's working with the primary care. It's working with the trust. And it's showing what else can be possible.
Okay. I want to just see if there's questions out here. Yes.
Thank you for taking the question. David Pyatt, former Chairman and CEO Allergan. So for Dr. Moore, clearly when I listen to the hurdle of reimbursement, is there a model to go and talk to major insurers in a geographic area and say, look, let's look for an old-term gain sharing, right? So we can offer care at a lower price to you. Presumably there would have to be a trigger for the patient to opt in. Obviously you can't just tell them to go home. That'd be difficult. Is that the biggest hurdle, or is it even internal? That, of course, if you were to start externalizing 20% of your care, you'd actually have overcapacity in your hospitals. Which is the bigger one?
I think your point is excellent. You have to have a systems approach to transformation. You know, we've been on a 10-year journey and we're only so far right now. We have to absolutely get financial alignment. We have to get operations alignment. We have to retrain our workforce. We have to get people to understand you can go and do clinic visit, virtual visit, live, virtual visit, asynchronous, and it's really engineering around what people need. The financial model, there are financial models out there. I've spent some of my life in the insurance side of the business, and you know, the insurance side is, if you will, capitated. They have a whole dollar. We have some models inside of Mercy now where we share the entire dollar, not just risk. There's others, we have a risk corridor. We might have a plus or minus 10%. But the key is to make sure the behavior that you're trying to drive to is rewarded, and that we get away from processes and units of healthcare into outcomes. So the alignment of risk around outcomes and then rewarding people for going there. And there, we believe, strong pathways to make that happen.
Okay. One more question in the back there.
Yes, hello. This is Ron Gutman, the founder and CEO of HealthTap. To pick up on one of the points that Randall just talked about, which is collaboration and bringing things together. So the question is for Randall and for Eric, that was inspiring us with medical devices and connected sensors that are coming together. How can we bring together developers on the one hand and doctors on the other hand and healthcare systems to actually collaborate and build meaningful systems that actually talk with each other? How do we bring some of these sensors that are managing one use case, right, and put them all together to actually share data between them and empower doctors to make better decisions about health and well-being and share them with patients? Is it a time to do a health cloud that bring it all together?
I can start. When people come to Mercy and see this new state-of-the-art building, 125,000 square foot, first thing you ask is, why a hospital building for virtual care with no patients? And it's because, again, it's about a care process. It's about bringing together a vast ecosystem under one roof that can put the entire model together and transform the model to bring that to the person when and where needed.
I would add to that. It's not about the providers and consumers. It's about gluing everybody else. Because you may have the best technology to connect doctors to patients, but if the patient is not only paying a copay, but rather the full payment, that won't work. Right. If you don't utilize retail clinics as the remote extension of tertiary centers, then care is becoming really expensive. So we came up with this notion of exchange, of keeping all the players together so hospitals can provide services nationally to members of payers. Employers can tap into this opportunity to offer more choice to others. So I think that no one company can actually create this complete cloud system, but rather there has to be an electronic glue that takes the existing players and allowing them safely and securely to do that in a way that does not contradict their lens of business interests.